Welcome, everyone, to the Healthcare Security Seminar Series. This is a discussion into the evolution of healthcare security with me, Tony York, your host, and a few of my special friends and guests. I invite you to join me in learning alongside some of the brightest minds in the security industry as each session we take a deep dive into an important topic surrounding the safeness of healthcare. Workplace violence is a serious threat for all healthcare organizations. Often we think about violence in healthcare as the assaultive behaviors that's generated against our staff members, our care providers, by patients and visitors. But in this session, we're going to dive into the unthinkable act of active shooters with one of the world's foremost experts in the space, Catherine Schweit. And I love Kate, who is just an absolute expert in this space. I've had a chance to spend a lot of time with Kate over the last year and really admire not only the person she is, but the research that she's done. And after the tragic events of Sandy Hook Elementary School, the FBI resourced its active shooter program and turned to Kate to create the agency's active shooter program. She's since retired from her years of service, but remains very active helping hospitals, churches, businesses alike navigate how to prevent, how to respond to, how to recover from the issues of targeted violence. And she's also a crisis communications expert. So buckle in, as every healthcare security program, as we all know, must manage the active shooter, the hostile event response issues that we know we face. And I trust you're going to find some very useful nuggets in how to help you build your program. Kate, thanks for joining me and welcome to the conversation.
Oh, thank you so much for letting me be here today. I'm excited about it, and I hope that everybody does walk away with maybe just something they haven't known, or haven't heard before, and they take an opportunity to, maybe explore some things that they just haven't really thought about before. I just had a conversation. I just got off the phone with a reporter who was asking me about a follow up on a shooting, and they said, "Oh, this location is they're doing this extra work now. Maybe they should have done it before." And one of the things that I said to that reporter is, you know, um, one of the things that I've learned in all my, dozen and more years doing this is that it's a process. There's no perfect security program. There's no an absolute on security, but it's a building process. And every time, if you do one thing today in your program or one thing this quarter in your program that makes it better, that makes your customer base safer, that makes your employees safer, you are one step further along in your security program, and that's what I hope I'm able to help with today.
That's such a good point. I mean, incremental changes that we make, incremental improvements that we do, right? Just continuous process improvement is so critical to how we do it. I've got a friend of mine who I've worked with for a good number of years. He always likes to remind me Rome was never built in a day, but it sure can
That's
be
right.
torn down pretty quickly. But Kate, when you were with the FBI and you built out the active shooter program, and I think all of us remember Sandy Hook. I was sharing with my wife in advance of this program. She reminded me about the fact of how it impacted her. And we're in Colorado, and of course that's over there on the eastern seaboard. But when you think about what drove the FBI's active shooter program, tell us a little bit about how that body of work came to life. How did that really come about, and any lessons that you might be able to share with our healthcare security practitioners and leaders?
Well, I think boy, that's a fortuitous, a great spot to start because I did very much get dumped into it after Sandy Hook, the Sandy Hook Elementary School massacre was in December of 2012. And you mentioned that you're in Colorado. In Colorado, in July of 12, was the terrible Aurora Theater shooting, the shooting at the theater in Aurora, Colorado. And just this morning, I spent an hour with former police chief, Aurora Police Chief Dan Oates, who was at Aurora. And and at the time that when the theater shooting occurred in Aurora, our head of our office in Colorado um, was there, Jim Yacone, and Jim was standing side by side with Dan Oates through all the press conferences and in all the meetings. And the FBI came to the scene of the Aurora Theater shooting saying, "What do you need? Everything the FBI has is at your disposal." And one of the things that the FBI brought to the table was people to interview. There were 1,200 people in the movie theater, probably at the time, watching this movie that was being this Batman movie that was being released at midnight when the shooting occurred at in that theater. But the movie was running in a bunch of other theaters. I think it was a 12-screen theater, and there were 1,200 people in the building at the time of the shooting, and many hundreds of those had to be interviewed. And one of the things that the FBI brought to this table was bodies to interview people. We also provided support to back up and fill in where we were needed for their victim services to provide assistance to the victims. In addition to that, the shooter in the Aurora Theater case had set traps and bombs up in his homemade bombs up in his apartment building, not too many blocks away, as you know. The FBI came in and worked with local bomb experts because all the bomb experts in the country trained together, and they dismantled that apartment that was booby trapped. So the FBI brings in pieces of the whole of the way that we need to respond and recover at a scene. And what the FBI's goal is to fill in where you need it. Does the FBI need to be in and take over an investigation and do all the work for something that occurs in New York City? No. New York City Police Department's bigger than the FBI in terms of sworn officers. So we come into a community and we fill in the cracks where the assistance is needed, not just for that moment that an incident occurs, but for that moment beyond, in the day, in the next day, in the next day. Because as you can imagine, a shooting that occurs at the Aurora Theater, it occurs at midnight, 12:30ish. The personnel who were on stayed on. They were getting off shift, they stayed on. Those people were exhausted. They'd been up for 2 days, just in the first 2 days. It takes a lot of manpower to work a scene and to work the safety and to take care of the people. And the FBI's job is to fill in those pieces. And as we did that in July, we did that again in December when the Sandy Hook shooting occurred. It was our SWAT team was there helping to clear the building, look for the subject, and ensure that there was no other danger inside the building. But we also worked with we also provided victim assistance. It's a smaller community. Newtown is a smaller community. The state police was there. So Connecticut State Police actually ran that investigation. They had a command post right near there and they responded too. So I think that's how the FBI sees itself. That's how we've always seen ourselves, is that our job is to come in and bring in the experts, the specialty items, the people, the manpower. If there's 1,000 interviews that need to be done because of a tragedy, and we can bring in the personnel from all over the country to do those 1,000 interviews, then the local law enforcement agencies don't have to do them. We do them, we hand the paperwork over, and it takes the stress off of their personnel to do that, and they can focus on the things that they need to do. So when Sandy Hook occurred, we did just that. And at the same time, President Biden had asked for, President Obama had asked Vice President Biden to put together a team to look for solutions. And that's really kind of where I came into the story.
It's tragic that we have to, follow up with something like that. But it is amazing how we show resiliency as a society, and even with the resources we have, because we do respond. I've long said security is really incident driven, and so much of what we do is, what we learn from those events. And I'm thinking about Aurora, and my mind is flooded with those, because I had a lot of the hospitals under my watch that were the receiving hospitals at that point in time with Aurora. Right. So, probably a conversation for a different day, but the impact of the mass casualty in the heels of an active shooter event such as that happening in the community, which is an interesting thing. But it's amazing to think that it's just over 10 years. But when we think about the last 10 years, I mean, really, when we think about the most deadliest mass shootings that we've seen in modern American history, it's been in that last 10 years. And, and all of us cringe when we think about, the events. I mean, we're mentioning Sandy Hook, the Aurora Theater shooting. We think about what happened in Vegas. We could go on, and I think all of us just lose our stomach and just as it happens. But Okay, why are we seeing such an increase in the active shooter events, in your opinion? I mean, I look at an FBI study that was from 17 to 21, and we saw a damn near 100% increase in that 5-year period in these events. I mean, what can you share about those that are committing these acts? What have we learned about the perpetrators and the issues before we get into how we harden that target?
Okay, that's a great question, and, the answer is, I don't know. But the answer isn't exactly, I don't know. I think what I'm saying is that, it's in some ways, it's kind of early on to see why we're seeing a trend, an increasing trend. There's no question that we're seeing an increasing trend in incidents, these types of incidents, which are those volatile situations where a gun is out and civilians have to decide what to do and police have to respond. Active shooter incidents, incidents where an individual is actively engaged in killing or attempting to kill people in a crowded area. So what we have seen is, as we've seen the numbers increase from, you know, teens or maybe 20 in a year. Now it's 30 and 40, and year before last, it was 60. And I think that we don't have the numbers from the FBI for this just past year. We'll get them shortly, but the preliminary numbers show that they're going down a little bit, which is good. Um, but I think that it still speaks to the fact that the number of incidents are going up, even though I will say that the average number of casualties is going down. And that tells me two things. The casualties are going down per incident because we're doing a better job of training people, run, hide, fight, and prevention efforts. When prevention efforts fail, what do you do to save lives? Stop the bleed. Super important training. Run, hide, fight. Super important training. That's going to lower our casualty numbers, and I think we're beginning to see now that it is. But then the prevention, which is the crystal ball, right, that we're all looking for on how can we prevent. We have it's a moving target. I think that's part of the challenge right now. One of the biggest pieces of that moving target is social media. Um, Individuals who would never have thought about emulating the Columbine killers are now have their own websites, and so they are. Um, it's probably not the right word to say breeding, but they're encouraging each other because they're so close to each other, and they can create a community online, just like we always worried about in the 60s and the 70s about gangs that in your street, you had to belong to the gang because everybody belonged to the gang. And why did kids join the gang? Because they wanted to belong to something, and they maybe didn't have the right school structure or family structure or religious structure to
Mhm.
get to belong. Now you can belong online to a group that aspires to be mass killers. So I think that the online aspect of it and the social media aspect of it twofold, because one, the online communities that are forming, but then two, which are not just in the United States, they're international. But then two, the fact that so many people can convey their threats, the leakage is out there, and there's this emboldened way that somebody who is hidden and protected in their own space, behind their phone, in their bedroom, or wherever they have in their car, they can be emboldened to make statements and threaten, and it can help them to gain the courage they need at that moment to strike.
Yeah, it's interesting. This community. I mean, we're trying to create our own community with how to thwart and how to prevent and how to do that, right? I mean, that's what we continuously do in the security arena that we're participating in. It's mindful though. I had Robert Burns, who's the president of Paladin Risk Solutions, and we were chatting late in the fall last year about sort of what the aftermath of the Roe versus Wade change was going to do and how that was going to impact healthcare. And he talked a lot about, how we're now using the tools that are available to us. To really monitor social media, to really get a better sense of what's being said. And I know I find myself talking to healthcare organizations about the importance of doing that, right? I mean, how are we paying attention to what others are saying in a manner that will allow us to not just respond in the moment, but maybe give us a few extra minutes or maybe even more, because we're starting to hear that and paying attention to it. And I think we're going to see that type of behavior change over the course of time, and hopefully leveraging those tools to our benefit.
And I think, we all know that the security technology industry is billions strong, and there are so many ideas out there. And I think as they gel out into some of the most effective means, that'll help. Imagine what it would be like to geofence all of your, all your phones that walk into your hospital, into any location or in your parking lot, and get those geofenced so you could send an alert out to them right away. Is that being done? It is being done in some places. Is it being done everywhere? No, it's not. But it costs money. And that's part of social media. Scraping is one thing, but also alerting is another. And uh, I know organizations, industries, and hospitals especially too have struggled with the idea that we'll create an app and the app will be out there. Well, plenty of people don't want to download an app onto their phone. They don't want to volunteer into it. You can't be voluntold to violate private, to give more privacy rights away. And so that's a challenge that I think when people aspirationally came up with the idea of, we'll just create an app, they didn't realize that if you were not giving them a company phone, they were probably not going to put the app on their phone. And so it prohibits the ability to do the security that you think is that frustration of, I'm just trying to keep you safe. But I've heard that argument many times. So the technology is out there. I think there's some shaking out that's going to happen before we decide, what's affordable and what people are willing to pay in terms of the idea of freedom, freedom of movement, and cost benefit analysis for technologies.
Well, we've come a long ways, and we still have a long ways to go. And I have a lot of optimism that that technology will allow us to really make some big strides. But most people who listen to me chat, they'll hear I talk a lot about the fundamentals of blocking and tackling. Let's win that line of
I like it.
scrimmage. And and in healthcare, I mean, we're pretty well known for being 4 times more likely for a serious workplace violence event to happen. Most of that, as I alluded to in my opening, is much more assaultive behavior, physical aggression against our care providers,
Right.
who they're trying to attempt to deliver care, right? But last year we saw that, the active shooter, we had 2 real events that happened that spilled over into the healthcare delivery system. And I think that raised a lot of awareness to those in the space, but also to the court of public opinion about how we're keeping that space safe. When I got into the business, just getting the doors shut and having some controlled entrances was a monumental task. I would have told you, I've been in the business for over 30 years, and up until probably the last 5, I would have said that was one of the most fundamental risk facing healthcare. And when I read your book, Stop the Killing, you're talking extensively about that. I mean,
Doors.
and let's talk about
Doors.
locking doors. Let's talk, because I agree with where you took that conversation. And why is that so important to you, Kate? I mean, I know I have my strong opinion about that, but I'd love the audience to hear yours.
Yeah, I think that, and I'll tell you, if you're even thinking of getting my book, you might hold out another month, and I'm putting out a soft covered book, so it'll be cheaper. So stand by, as they say, and the soft covered book will be out and a little bit updated in April. But the in the book, and I do it actually in the school chapter, but then I say in the school chapter, if you haven't read the business chapter, read the business chapter. And if you haven't read the business chapter, go read the school chapter. But I just wanted to kind of divide them up, right? And I said, and I know what you're referring to, because I said in the school chapter, doors, doors, doors. Doors are so important. Doors are the most important thing that you can do to save people, protect people. And it's so much more complicated than you might think it is, because sometimes I'll talk to the president of a company and they'll say, well, just put a lock on all the doors. And then anybody who's actually working in the building knows there's no such thing as just put a lock on all the doors. Some doors don't have locks on them. Some doors have locks that you have to lock from the outside to the inside. Some doors have windows that you can see through to see whether you're protected. And some of those doors that have windows allow a shooter to shoot through them, like we saw down in Parkland, Florida. So doors are absolutely the most important thing. But the reason that is I just say this based on years of working and hundreds of shootings, to say every second counts. Every second counts. And if a shooter, if when the FBI, when I wrote the original research for the FBI, the one of the things that surprised me is that 70% of the shootings ended in 5 minutes or less, and half of those in 2 minutes or less. So if you can keep a shooter away from your area of the hospital, your room in the hospital, for a minute or 2 minutes, you not only can potentially just prevent the shooter from ever getting there when people are still there, but you can also keep yourself safe until law enforcement arrives on the scene, if they're not there, within 1, 2, 3 minutes. So law enforcement is aware that they need to get to the scene and get to neutralize the shooter first. And even in EDs, they often have law enforcement, maybe in the area. There may be secured and armed guards in the emergency rooms, in the emergency departments. But the idea that you can have a door between you and danger is no different than how anybody who's ever walked into a police department, those people sitting at the desk are sitting behind bulletproof glass. You don't have time to look for another spot. And a door gives you that protection in a way that nothing else does. And this is one of those technology things, right? There are companies that have come out, some that I've reviewed their materials. There's fantastic companies that have created ballistic doors and doors that can handle shotgun rounds, doors that are very lightweight, doors that don't look like they're ballistic. I mean, there are great products out there, and you have to kind of make that call about whether or not you can afford those doors and how you can afford them, and where you put them in your facility. I mean, doors, there are hundreds of doors in everybody's facilities, and that creates that challenge. So the job for security is to decide which doors need to be the fastest, the most, secure doors that can't be shot through if there's a chance that will risk the better part of your hospital by letting somebody through that door.
Yeah, so the type of door that we install is obviously a very important piece, and in so many circles, the term value engineering gets brought into the equation because, form does follow finance in so many ways. And I hate to say we're ever putting a price on any of these lives, but because so many inside of the decision-making tree have historically said, this isn't going to happen here, right? I mean, we're not
Right.
going to be, it's happening elsewhere. And I think we're now, for the first time in my time, serving healthcare, is we're starting to see that change. We're starting to see, are we doing enough? Are we asking ourselves all the right questions? I'm still in the mindset, Kate, that we need to at least make certain we have control of where people are entering, what more we can do to create a safer environment. Can we actually see that long gun in
Yeah.
advance of the person coming in, recognizing that's not going to be everything that we're ever going to try to thwart. But in the same vein, there are a lot of ways that we can harden that target. And,
Yeah. You know,
so please.
Tony, I just wanted to say, a great example of that is I do a lot of consulting with hospitals. My favorite sister, which would make my other sisters mad that I said that, but I'm a lawyer. My other sister is a lawyer. She's a hospital lawyer, general counsel. And so we have a lot of discussions about hospital security. We have for years had hospital security discussions. So I'm kind of a CMS, duty of care, ask me about Entella. I mean, I feel like I've got it all in my head, like I'm a hospital attorney through the years. I was consulting with a hospital once that had they had their outpatient facility on the second floor of the building. And there was free access to that second floor, and nobody that checked and then from the second floor, you could go any place in the hospital, of course. And so essentially they had, what I thought was as volatile as any other location, tons of people, because you know how those facilities are. You have so many people coming and going through the outpatient care facilities. And yet there was no check system. Security never even made rounds on that floor. It kind of surprised me. I was like, well, what if there's a problem up there?
Yeah,
So
it's a big
no security at
concern,
all.
Kate.
Yeah,
I mean, and so many, and let's face it. I mean, one of the hardest decisions for these healthcare administrators is what are they allocating resources towards?
sure,
And unfortunately, we're just now starting to move away from the art of security to the science of security. And I say that specifically because we have not been an evidence-based industry. We've only
hmm
been opinionated. And we're now starting to really move into that as space. And I think the hospitals are starting to understand how does the security posture they're looking at, how does
sure.
that
And
really
where do you,
fit into
yeah,
their overall risk tolerances, right? I
right.
mean,
Where do
that,
you put your money, right? Put your money
yeah,
where your mouth is, right? In terms of risk tolerance. Absolutely. I didn't mean to cut you off, but
that's okay.
that, that is exactly the problem. And I think we do have a lot more evidence that tells us that. We know
Right.
now, when we didn't 50 years ago and less than that, the biggest threat for an active shooter situation is in your emergency room. Doesn't mean that's the only place where somebody's going to come in shooting, but that's the most likely place. We know that security that carries guns in an emergency department, we have officers who have lost their guns in struggles. So security who carries gun, who security that's allowed to carry a gun in an emergency department has to be, you have to budget not only for the employee and their insurance, but for their training. And they
Right.
have to be super well trained in order to carry that weapon. Otherwise, they shouldn't be carrying it. Otherwise, it's more important to train them in de-escalation. We all know that security is just a cost code for a lot of people, for the industries, and so you have to decide to prioritize, because you can never put enough into it to make the target that you want to protect as hard as it needs to be.
Yeah, I would agree fully, and I've long said if I could figure out how to measure what didn't happen, boy, we could get a lot of resources allocated to really making a more aesthetically pleasing, secured environment. I mean, obviously, we don't want to create a security state in how we're creating these hospitals, which is one of the things I think we're always trying to manage. And I see one of the questions about, hey, should we be introducing man traps? A
Right.
guest previously, he liked to refer to them a little differently. He called them elopement buffer zones, which is keeping people who we didn't want to leave from leaving. But in the same vein,
They
there
both work.
are,
They work for
there,
both,
they
right? Because
do. That's
hospitals are
right.
responsible for elopements too, right? And
Yes.
so they do work for both, but you got to have somebody who's on the button, right? To
Yeah.
hit that button and get that second door locked.
And I think that's where we're trying to move. I think that's where healthcare is starting to go. I was chatting with, Alan Butler in our last session. We were focusing mostly on body worn cameras, but our conversations lean into metal screening and weapons detection, and the evolution of that technology is making strides. I mean, every single day, and we're starting to
hmm
see a lot more organizations introduce that technology. To your point, most of it is in the emerge, but not all. We're starting to see organizations think about, hey, do we have this in other locations? Should we actually have all entry points that the public is coming in? And now they're even asking their questions about, well, let's think about our own staff members themselves. But knowing that how we harden that target is multifaceted, let's maybe move our conversation a little bit, Kate, to the whole mindset of you talked about earlier, the active shooter, the learnings that you've got was we believe that this thing is going to be over in about 5 minutes. And often what does that mean? It's before law enforcement arrives. So we're trying to find a safe space. But I know you're an ardent supporter of run, hide, fight, and I think that's the training curriculum of choice for most healthcare organizations. But tell us why you think that type of training for our masses is so important. And make the argument, help the folks that are listening to you make that ROI argument, or at least make the moral argument for why we ought to be investing in that training itself.
Yeah, I'm glad you asked me that question, because I think there are a couple of answers, and I hope I can cover all of them. The FBI, DHS, Department of Education, HHS, we all endorsed Run, Hide, Fight, and from the summer after Sandy Hook forward, that has been the federal government's position. And Run, Hide, Fight is there are many companies that have created training programs before and after that train essentially the same thing. So I don't care what word you use, but I'm telling you that run, hide, fight is a great way to identify what actually occurs in these incidents. And that's after looking at hundreds of them. We know every instance there are people who run, people who hide, and in some instances, people who fight. So it's important to know for that training, to talk through that training, especially in a hospital setting for your personnel, to know what those options are so you don't freeze. The last thing that we want anybody to do is freeze because they can't decide what to do to keep themselves safe. The other reason why it's so important, particularly in a hospital setting, is that everybody who's working in the hospital setting, uh, there's a good chance that they are there in a position to care for others, even if it's answering the phones or meeting somebody in the emergency room, pushing an orderly, pushing somebody down a hallway. Certainly for nurses, doctors, PTs, OTs, all of those people are focused on patient care, care of others. If you don't train your personnel in run, hide, fight, you know what they're not going to do? They're not going to do the run part. And I can tell you that the best experts in hospital law say one of the biggest failures in run, hide, fight training in hospitals is a failure to discuss and give your employees permission to run, even if they must leave people behind.
The
Your
caregiver's
job,
dilemma, right? I
the
mean, it's the
caregiver's dilemma.
caregiver's dilemma.
And
Yeah.
we've all talked about it. You have to give your employees, and through training, you do that. If you give your employees permission to leave, to save their own life, you've given them a gift they can get nowhere else. Many times employees feel a sense of obligation to lock doors or turn off computers. We saw that as far back as the Twin Towers, where people were running around the apartment to shut computers off, thinking they needed to do that because that was the rule before you left. You know, the building is burning and they're shutting computers off. People are, employees want to comply with the rules around them. And complying with the rules around them means taking care of those around them. And you need to do run, hide, fight training so you can talk through what do you do if you're in a surgical ward? What do you do if you've got somebody in an MRI? What do you do if you are the 3 people taking care of the 20 babies? So whatever that is, you can't, if you don't talk through those things, you don't give the employees the chance and the permission to make the best decision they can at the moment. Because that's what it all comes down to when it comes down to training is everybody has to make the best decision they can at the moment. And the most valuable part of them being allowed to do that and doing that is how they recover. Because employees who, and the law enforcement and employees who, and people who question whether they made the right decision have a very, very long road to recovery in front of them.
Yeah, it's such a personal choice for these folks. And to your point, we're trying to really bring awareness to what would you do if you're facing that situation. And I think one thing we all know about the importance of training is that folks will lean on that training in their moment of crisis. And they will fall back into that, even though they may not remember it if we ask them to take a quiz or take a question on the hills, but they will in that moment. And so much of that is, it's professional opinion. Sometimes their decisions could be influenced by what they may feel as their moral or ethical obligations. Some may even bring their religious and other viewpoints into the conversation. And, Kate, when you've had the conversation with hospitals, and I know you've worked a lot with hospitals, what have you found has worked the best when you're addressing this issue with those caregivers for how to make certain that they understand? I mean, I love the idea of we're giving them permission. And I think that's such an important piece that the expectation is not that we expect you to look after your patient first and put your personal safety second. I mean, and so I've always said, put your personal safety first. That's the only way you're going to keep others safe. But any other insights, any other kind of things that you know have worked well for the caregivers you've chatted with over the course of your career?
Yeah, I know that time is a premium in hospitals. There is no time. Every employee works too many hours and too long of hours, and there's never enough staff. So with that qualification, I say, um, when you walk an employee through in a drill, a brief drill, right? You can do it in a very brief time. You could, as
Mhm.
a security officer, go floor to floor and say, "Hey, on your shift today, when you come into the nurses area, we're going to just talk, for 10 minutes about what would you do if something happened." And you take the opportunity to point doors to them, show them how to walk through areas. You walk through and you ask them, what would prevent you from evacuating this area? What is your concern? If a security officer, uh, if a security chief made a decision that their team was going to break the hospital facility into parts in over 6 months, interact with every floor, that would be tremendous, because it's in not just the words, but the idea of getting their opinion about what they personally would be concerned about and their assessment of their floor and their space and their room and what the challenges would be. If you don't know what those are, how can you properly advise them about what they are? And then on top of that, if they talk it through with you, and I know companies that come in and do just exactly this. I have a good friend of mine who's his Eric Munchak, his company comes in and does this. I've done it with him. Um, but you can have an outsider do it. You can do it internally. You can have an outsider test it, and then you can mimic it. Um, you it gives it gives them an opportunity to see that they know what the best choices are. I'm not sure if I'm saying that right, but what I'm trying to say is that there are always going to be a lot of choices, but by walking through some options, talking through some options, physically walking through some doors and seeing what opportunities are, then you see that it's a reality. Maybe you can really get 20 babies out of there. We've seen that happen in emergency situations with hospitals and daycare centers. How do you safely move those? Maybe the room where the babies are, where you can't safely move babies, is the room where you put a ballistic door, and a safe space, right? And maybe that's a consideration. It's not because you don't care about the other patients in the hallway. It's because the personnel can't move those babies the way that maybe other people might be able to be moved in the emergency department. But those are the considerations you only know if you get to the floor. But in addition to the run, hide, fight training, I think you need to do the walkthroughs, do the drills, even if sometimes people want to do big day-long drills, but 10 minutes is so effective. 10 minutes is so effective.
Yeah, I mean, tabletop exercises, right? I mean, just walking through the staff and say, give them a scenario and letting them see it. I would also add, Kate, I have long thought we have to train our leaders in these areas even further to help them be able to have the conversations, to take the one that pops up in a staff meeting because something they may have read in the news or it happened elsewhere, and they're bringing up the issue and saying, okay, how do they address that situation in that moment? Because although as security we want to be everywhere all the time to the best of our ability, I think we all know that that's just not physically possible. But but to what you said, I mean, our continuous rounding and leveraging that rounding, especially as leaders. In healthcare, we do environmental care rounding pretty much all the time. It's an expectation
Right.
that we're doing that. It's part of the hazard vulnerability assessment processes. I mean, it is something that we can, I think, leverage as how are we bringing that conversation? Because it's interesting. I've been around. If I've been around for 30 years, that means I'm an older guy, right? So, but I look at my kids who, one just graduated college, others in it. But I think about their elementary, their middle school, their high school experiences. They had this training. They grew up with this. I
Right.
mean, where we were thinking about fire and tornado and nuclear kind of stuff, I mean,
Right.
they're thinking about run, hide, fight and learning about these kind of issues. But there's a whole generation that is deeply embedded in our workforce. I don't think they've had this. And so I encourage folks, don't make this a one and done kind of conversation. I mean, how do we continuously bring it to their attention without using fear as our factor,
Right.
without trying to make people scared to come to work and doing it, but recognizing that there is a realism associated with the challenges
Yeah.
that we could face. I mean, as
And
unlikely as it is.
let's talk reality, right? I mean, hospital shootings that turn into active shooter situations are exceedingly rare.
Right.
But that doesn't mean that guns going off in emergency rooms aren't, right? I mean, they happen. Where do we see guns going off in hospitals? You guys know better than I do, but primarily in addition to the emergency rooms and in addition to the parking lots, the murder suicides that occur sometimes on floors when somebody is very ill, and also occasionally those conflicts that occur on the floors in the nurses are in the middle of it, right? So having the conversations, not one and done, not thinking that the only thing that we're really going to plan for is if somebody comes in with 100 magazines locked and loaded into a semi-automatic rifle. There's a lot in between. And if you think that that's the only thing you're training for, you're not really going to take it seriously because you're going to say it's never going to happen here. So it's important in your training to talk from the most extreme all the way down. Just like when you do security training and safety training, you talk about the tornado that's going to take the roof off the hospital, but you also talk about the power outage, and you also talk about the potential flooding. They may be less devastating to the departments, the car that rams through the emergency room or the front door of the hospital because somebody's foot hits the gas instead of the brake. Those are all security emergencies. And you want to tend to all of those. You want to say these are all security training matters. And I would encourage hospitals who all have good security emergency planning because they're required under HHS rules and CMS rules, to wrap training for shootings within and talk about it in terms of safety and security training, because then you won't scare people as much. It'll just, because I agree with you, Tony, what you just said. We have a generation who has grown up with this kind of training from elementary school on and more, and kids who are in colleges where shootings occur were in high schools and receive their training. People in businesses have been hearing this kind of training for a long time. They know what run, hide, fight is, just like their kids do.
Yeah. It's interesting, Kate. I had a good friend of mine who did a lot of research. It's a little dated now, but he basically looked at what was in the literature and secondary research for the discharges of firearms in healthcare. It was from the period of January '06 through December of 16. So it's an 11-year period. Pretty
Pretty
interesting.
good.
416 instances that he was able to define that were firearm discharges that happened. Of that, only 7 of those fit the category of what we would define today as an active shooter. What most of them were, the largest 30% of all of them were suicidal ideation or suicides themselves. And, that's an interesting subject in its own right about why people think that they should come to the hospital
Right.
to actually commit that act. And I've talked to a lot of psychiatrists about it because early on I couldn't wrap my own head around it, but as they said, it was a matter of they believed that the hospitals were much more ready and prepared and apt to
Right.
handle the mess that was left and what was going on, and that they probably didn't want their family and their friends to be the one to find. And I
Right.
think that's it's really interesting. The other 15% of them, Kate, were basically due to another crime being committed, right? So
Mm-hmm.
somebody who had a firearm there, but that was embedded. But the third, there was a little bit of a tie, but one is very apropos to healthcare, and I think in one of our highest risk processes, and that's when we're serving prisoners as patients and the
Right.
escape attempts that happen and everything related. But basically, even with that is the domestic disputes. I share that because I think it's important that we realize the firearms are coming inside of healthcare. And we have to be prepared not only for that, but then how does that turn into something more when we start thinking about the definition of an active shooter? But if I go back into some earlier conversations, you mentioned duty of care. You mentioned if you were to talk to the hospital C-suite, the CEO, the
Mhm.
COO, the CNO, or whatever they may be calling them in that particular health system, health or health authority, what advice would you give those leaders when it comes to how best to prevent and how best to mitigate? But also, maybe let's start moving our conversation into helping them understand how to best recover from such an event.
So that's a great question, and I have had these conversations with a lot of. That's a lot of times where my consulting work falls is, I get a call from the team that says, we think we're wrapping our heads around this whole idea of making the hospital safer, but then what do we do as leaders and managers? Where are our policies on it? And so I think you start with, and what I always say is, let's start with your policies and see if they're good. Do you have policies that say your security carries guns when they don't, or vice versa? So make sure your policies are clean, because if you don't, then in the aftermath, you're going to spend a lot of money on legal fees and lawsuits. So your policies, are they clear to give your employees directions on how to care for themselves? Because they have, as much as the employees are thinking about the caregiver's dilemma, the hospitals, of course, have a duty of care to their employees that is no different than any other employer, and they have to have policies in place that show that they made that effort. So you have, not only do you have to have the policies, you have to document as a team, um, how are you actively evaluating on a regular basis? And that may be every 6 months or every year or every quarter, depending on, say you have, a variety of facilities or rooms. Maybe you're only doing certain departments every 6 months. How are you evaluating changes that you could make, or uh, kind of documenting that you've created a safer environment for your employees? That's a good thing to do, because you can't always, as long as we hire from the human race, you can't even hope to not have an employee, right, who is the instigator. But human nature, is a little fickle, and if somebody can come in off the street, it's going to happen. Um, you can't prevent it. You have to be able to document that you did what you can from a legal standpoint. I hate to sound like a boring lawyer, but I am actually I'm an I'm a certified compliance and ethics professional too. And part of the compliance issue is um, showing that you've evaluated your own programs to see whether or not you are following and doing what you can with regard to that duty to care. And then the other thing that you talked about is from a recovery standpoint. So that duty to care, and just to be clear, it should involve training. It should involve the ability to train people on a regular basis for stop the bleed. Not just your nurses. Run, hide, fight. You can develop your own program for stop the bleed, right? Because you've got the skills there. Run, hide, fight, stop the bleed, and also developing the concept of see something, say something, know where and how that information can be collected, who is your threat assessment team. And then when it comes to recovery, I always have lots of discussions with the C-suite personnel about, you need to have your own crisis intervention team, your crisis response team that works as a go-between between law enforcement and incident managers. They're incident responders in fire, police, and the other departments, and your separate company. There has to be a team that's available and ready to support them um, when they come to the scene. They don't necessarily know the configuration of your hospital. They don't know how to turn off the water. They don't know how to turn off the electricity in certain areas. They don't know how many people are in the building. They don't know what areas of the building have MRIs in them and they shouldn't walk in, right? With all their gear on. So those kinds of things can only be provided to responding law enforcement if a team that's authorized from the executive level is prepared to step in and participate in a press conference to provide support to law enforcement and fire as they attend to the scene, and also to create the fall away places for all the extra sites that are going to be needed. When an incident occurs, and if the most volatile incident occurs as active shooter type of incident in your hospital is roped off. Nobody's getting to their cars. Nobody's getting to their purses wherever they might be. The people who are stuck in one area might be shuffled to another area. And it's important that that executive team, and you can lead this as a security chief, it's important that executive team know and have relationships with the buildings that are around the hospital facility, the hospital campus, to say, here is our alternate location to move the babies. Here is our alternate location to move patients. I know you have a lot of those, but what about your alternate location so law enforcement has a safe place to interview people who might have been involved? What about law enforcement's looking for a location where they want to put their evidence team, where they want to put their press conference? All of those alternate locations can be identified ahead of time as part of your crisis plan. But a lot of executives, first of all, it's not necessarily their job to know it, right? It's the security team's job to know that they need all those extra alternate sites. And second of all, they're busy focusing on so many other things that don't just have to do with security, right? So that's kind of your job. But that's what when I stress to the crisis, when I stress C-suite, I say, these are the before things you need to set up, but here's the after things that you need to have set up.
Yeah, and it really strikes into the whole continuity of operations, right? And that may not just be the security teams. It's most likely going to be multidisciplinary. We're going to need
Yes.
our colleagues from emergency management and probably risk and quality and others as well as that gets built out.
Facilities.
Oh,
Facilities,
absolutely.
always forgotten. Facilities, HR, people don't think about facilities, but facilities is the ones who can get you electricity when you in some place in the hospital that you didn't even know you needed it, right? They
True.
can shut power off, they can turn power on, they can create air conditioning where it didn't exist before. When the shooting occurred at Los Angeles International Airport, and there was a TSA officer killed, in order to open the hospital back up, the operations manager for the airport brought in facilities teams, and they built a wall inside the terminal where the shooting had occurred overnight so they could continue operations in the terminal and law enforcement could continue their investigation on the other side of the wall. So
Amazing.
it's you're only limited by your own imagination.
Yeah. You talked about one of the key elements of recovery that may be more immediate need, and that's the crisis communications. And I've met some wonderful PROs or the public relations officers inside of healthcare, and they're some of my favorite people, but I think they would also tell you that they're probably not as versed in this arena. Kate, what would you do, or what advice would you provide somebody who's trying to build out their policies, build out their coup planning along that space? Where would those folks turn to really get a better sense of understanding the knowledge that may help guide and steer them in such a circumstance?
I think there's two ways to go about it. But I think I love that you bring this up because uh, crisis communications is one of my personal, babies. I was doing that long before Sandy Hook for the FBI, and I'm well versed in standing in the cold and writing the points for a press conference and then just throwing them up out in front of a microphone or handing them to a police chief to have that police chief, have her read them out. And so that kind of activity calms a community immediately, and crisis comms is so important. But most people who do communications in hospitals, have limited experience in that area. And a lot of times comms is handled, maybe out of HR. When it comes to the tree of where it comes from, or maybe out of the president's office or the COO's office or something like that. But it never comes out of security necessarily, but every hospital should have a designated crisis communications expert. And in order to get that expertise, they can get it. I strongly encourage them to get it only from somebody who has a lot of experience in the area. I mean, I've done it for the FBI for years. I know plenty of other people who've done it for the FBI and other departments. but also it's not just, hey, call me. I'm happy to talk to anybody about it. Um, but there are also departments that have had to deal with crisis crises like this, and those law enforcement crisis comms people are so good at it if they know what they're doing. So there's a lot of people out there. Watch a press conference. Look at Chris Rosman and what he did at Michigan State University just over the last, just recently in the shooting. You watch him at a press conference and you'll see somebody who knows how to handle crisis comms. And that's what you need. You need to know the before, the after. And actually, we developed a crisis comms kind of emergency cheat sheet that you can see. I think it's on my website under my resources, catherineschweit.com, and I think you can pull it off the FBI's off the internet somewhere. Is a crisis communications plan for what is that first press conference going to be. I can't describe to you, if you have not been involved in one of those press conferences, how ill-equipped a regular comms person would be to handle one of those matters.
Yeah, having gone through that training, I was amazed at what I thought I knew until I went through the other side and realized how different it is versus every other component of communications that happen. In so many places, as you allude to, they don't typically fall. So I think it's important to note that, some training on that ahead of time. You can drill and exercise that in its own right. And a lot of advantages for organizations that are much beyond the Asher conversation that we're having right
Right.
now.
Yeah.
But it
Let
would
me just give
obviously
you
be very advantageous.
two quick mistakes that people think of who've never dealt with it from a crisis comms. The press conference is not going to be where you think it's going to be, and you're not going to be in charge of it.
Right. Amen. Amen. Well, Kate, I have to say, with just immense gratitude, you're a wealth of knowledge, and I remember the first conversation we had, and just knowing that, my goodness, I was just excited to know we had someone of your caliber focused in on this particular issue and putting a lot of attention on our healthcare delivery systems. I know that healthcare is not your only market that you spend time in, but I know you've got such a love for it. I know you've got family members that have dedicated their careers and their passionate pursuits to it. But let me just say, thanks for spending time with me and the audience today on this subject. I would encourage anyone that's really wanting to learn more. I'm sure you've probably, like me, taking copious notes. You're hearing a lot of things that you said, geez, I thought I had a good handle on it. And there's even more to continue to be focused in on. And we could probably spend all day talking about the how we harden a target, the next day on run, hide, fight, and all the benefits of what we could do and the techniques that we have. But we wanted to give a little taste of what was going on. So really appreciate you doing it as somebody who's an ambassador for the healthcare security space. I just say I really appreciate what you're doing for healthcare, what you're doing for our society as a whole. Your give back is so appreciated, and
Oh,
not just
thank
by
you,
me,
Tony.
but by so many. So thanks for taking that time, and for all of you who've listened, and I know we're coming up to the end of our hour, but please, the survey that will be coming, please complete that. Share what you liked, share what you may not have, how you would like us to explore a little further, and what you'd like to learn more about in the future. And I've got another really good guest lined up here for the next time we get together. We're going to get into a conversation that Kate will probably be near and dear to her heart as she's mentioning duty of care, and that'll be the issues of negligent security in healthcare. I've got Bill Marcise, who's another lawyer. You guys are going to be wondering why I keep bringing lawyers to the conversation. But I think it's a subject that we all have to be very mindful of to really protect the interest of our organizations. But with that, stay safe, stay diligent, and stay aware. Kate, thanks again. Take care, all.
Thank you. Be kind.